Hello and welcome to the Big Debate. I'm your host, Iguma Gabriel. Today is the 1st of December, which means Uganda joins the rest of the world in commemorating World AIDS Day. Uganda has come a very long way. From the mid-80s, when Uganda made global headlines as a country that had been hit by HIV. In the 90s, Uganda was being praised for the way we had reversed the HIV prevalence in our population. At that time, HIV was a death sentence. Almost everybody that got HIV was expected to die within a very short period. That has changed significantly. Something else that has changed, at that time, HIV was mainly seen amongst the adults. Today, HIV rates in the young people has increased, particularly girls between 15 and 24 years. What does that mean for Uganda's fight against HIV and AIDS? The world has set a very ambitious target to have no AIDS by 2030. Is that target achievable? This is the Big Debate, and we welcome you to the discussion. Let us meet our panelists for today's discussion.
Our panel tonight. Dr. Nelson Musoba is the Director General of the Uganda AIDS Commission. He has previously worked at various levels in health systems of Uganda for the last 18 years. Dr. Musoba has been key in implementing reforms over the last 20 years in the health sector. He has also previously worked as a senior health planner in the Ministry of Health, responsible for coordination of the Global Fund for AIDS, Tuberculosis and Malaria Uganda office between 2007 and 2012. Before joining Uganda AIDS Commission, Dr. Musoba worked as a project director for the monitoring and evaluation of Emergency Progress Plan project. Dr. Nelson Musoba joined Uganda AIDS Commission in 2014 as Director Planning and Strategic Information to coordinate the Directorate of Planning and Strategic Information. In March 2017, he was appointed Acting Director General until Feb 2018, when he was confirmed in the position. Mr. Jotham Mubangizi is the Acting Director of UNAIDS since he was appointed in November 2020. He was also UNAIDS Strategic Information Advisor for the last 12 years. Mr. Mubangizi was instrumental in supporting and strengthening HIV/AIDS monitoring and evaluation systems for the country to meet the national and international reporting obligations, analysis and modeling the impact of HIV and AIDS and support prioritization. Prior to joining UNAIDS, Mr. Mbangizi worked for several organizations, including Makerere University, World Bank, Rockefeller Foundation, Catholic Relief Services, Infectious Disease Center, AIDS Information Center, and Mulago STD Clinic. Ms. Sharifa Nalugo is a peer supporter at the Joint Clinical Research Center. She represents peer supporters in East Africa on the Pediatric Adolescent Treatment Africa Pattern Board. Nalugo is a gender-based violence champion representing young women to fight gender-based violence and represents young people on the Uganda Country Coordinating Mechanism of the Global Fund. Sharifa is an advocate of change, especially on issues concerning stigma and discrimination. Her passion lies in fighting HIV, AIDS, and stigma and supporting young people adhere to their treatment. Sharifa was crowned by the Uganda Network of Young People Living with HIV as the first Miss Young People Living with HIV in 2014 campaign, focusing on fighting stigma and discrimination. Ladies and gentlemen, our panelists.
There you have it, our panelists for the Big Debate today. Of course, you realize we have a slight change in panelists. Yes, Dr. Musoba wanted to be here, but unfortunately he's indisposed. But we have his able Deputy Director General, Uganda AIDS Commission, Dr. Vincent Bagambe. We're glad to have you. Dr. Vincent has over 24 years experience in HIV and AIDS, tuberculosis, and we could go on and on reading his credentials. But like I said, he is able deputy, and we're glad to have you on the show joining us. Dear viewer, would like to hear from you. So if you have any questions or any comments, remember to use the hashtag CTV Big Debate so that it's easy for us to find your question or your comment. And if it is a question, please tell us who you would like that question to go to, and we will direct it to the correct person. Dr. Vincent, let's begin with you, because even as we talk about Uganda's fight against HIV and AIDS, it's important to know where we are at. What are the current figures?
Thank you very much, Gabriel, and good evening to you, our dear viewers, this evening. As you heard, my name is Dr. Vincent Bagambe, and I am standing in for the Director General Uganda AIDS Commission. Regarding figures, Gabriel, I think you started it off very well. In the 1990s, Uganda was in a very hopeless situation in as far as HIV and AIDS is concerned. Acquiring an HIV infection was a death sentence. But as we talk now, we have made big progress as a country. We estimate that we have 1,400,000 people living with HIV in Uganda. And out of those 1.4 million people, we think that, actually that one we know, that we have 1,200,000 people on treatment. So that is a big progress. That translates to about 94% of the people who are living with HIV and AIDS being on treatment. If you compare with countries, including those surrounding us, and you'll hear more from my colleague who represents UNAIDS here, Uganda is among countries that have been able to achieve the targets for 90-90-90 that we had set for the year 2000.
We now have 95, 95,
and
95.
Now we have set a new target that by 2025, we want to have achieved 95, 95, 95. And because of that achievement in terms of identifying our HIV positive people and putting them on treatment, we have seen a tremendous reduction in death. If I compare the death that we're experiencing, say 10 years ago in 2010 and right now, in 2010, just 1 year, we registered 54,000 Ugandans dying because of HIV-related illnesses, AIDS-related illnesses. This last year in 2020, it was 22,000. So cutting it from 54,000 to 22,000 is a tremendous achievement. In terms of new HIV infections, because that's another parameter that we are tracking or monitoring. In 2010, we had an estimated 94,000 Ugandans infected with HIV in 1 year like this. Last year again, in 2020, the number was cut down to 38,000. So again, that shows you that we are making tremendous progress. We aren't where we are, but where we want, but at least we've made progress. Now, the unfortunate bit is that as we reduce new HIV infections, there are some subpopulations, especially the young people, adolescent girls and young women, especially the vulnerable populations. We include here, for example, young girls who are engaged in commercial sex. We are looking at young boys who we could say in relationships, say relationships with fellow men, but also relationships that society tends to think are unnatural. We are seeing high infections there, and we are seeing low enrollment into care in those age groups. I mean, in those categories of our population. Then we are seeing that children less than 15 years, we are getting less of them, and we are putting them less onto treatment, and even those that we get onto treatment, it's difficult to keep them there.
All right. Thank you very much for starting us off. I'd like to bring Sharifa in as a person living with HIV. When you hear these figures, the fact that, the prevalence rates have been brought down, what is the life of a person living with HIV like in Uganda currently? Because there's a time where it was a nightmare.
Yeah, I agree with you. There was a time where it was a nightmare. I mean, being born with HIV and having to go through the stigma and discrimination in my community and at school, it was worse. But when you look at the current trends, I mean, people are trying to understand more about HIV, making themselves, be aware of what is happening in the country. You see even right now young people, now attaching themselves to the figures. They know exactly, how many numbers of people are living with HIV. So they know the figures themselves. So we have that. There is a space for people to understand and know about HIV. But also when you look back to, despite everything being done, you might look at why are we still having the new infections. We have the treatment in the facilities. We have peer supporters like me, talking to the people and sensitizing about HIV, and we have very many people who have come out openly to, address this situation, but we still have those numbers. We want to reach a point where we don't have those numbers. If we look at, I might say when you look at the way that information is being spread, information is brought to the people, I think we have those that we do not reach. So for example, as I talk to many peer supporters or many young people out there, they like to say this word that information is in Kampala more. And in our villages, it is not there. In our villages, you find someone who still thinks that I can get HIV just by sitting near you or just by sharing a cup of tea. That basic introduction of HIV that someone should be, aware of and knowing. And we're still having these people who still think in this way. So I think we've done much effort and we don't want it to go to waste. So I think it's high time for us to go back to the strategy on how we were, giving the information to people in Kampala, like they say, and then make it, structure it down to the roots so that everyone could understand deeply what HIV is. I think by that, we are closing that up at some point and we are making people aware of how they can prevent themselves from getting the HIV virus, especially the adolescents and young people.
All right. Mr. Mubangizi, if you could give us a global perspective and where Uganda finds herself.
Thank you very much, Gabriel. I'm Jotham Mubangizi. I'm the acting country director for UNAIDS Uganda Country Office. Today we commemorate and celebrate the World AIDS Day. It is 40 years since the start of the epidemic. And globally, 2 days ago, we launched the Global AIDS Report, which saw that about 38 million people are living with HIV and AIDS. Of those, the majority, more than a half, are in Eastern Southern African region. That means that the HIV epidemic is still more concentrated in Eastern Southern Africa and Africa in general. We also saw that close to half of the infection also happening in Eastern Southern Africa. And we also saw that 6 in 7 new infections among the adolescent girls, 15 to 24, 6 in 7 of the new infections occur within those girls. And we see that there is a crisis going forward. and the issues of COVID have made it worse. We've seen high teenage pregnancies, and we warn, UNAIDS warns globally and within the region that unless we address the issues that confront the adolescent and young girls, then we are likely to see more deaths, we are likely to see more challenges. So the inequalities around gender-based violence, issues of stigma, issues of discrimination, issues of human rights abuses, those still remain the key challenges. But there is a hope with the new strategy. There was a global aid strategy that was launched in June 2021 by UN member state countries. If that is implemented to the dot, so we call upon, as I end, we call upon the political leadership, the religious, the cultural leadership, to be able to come out and address those inequalities, because swallowing a pill alone will not end HIV and AIDS. Thank you, Gabriel.
And Uganda's, fight against HIV, from where you sit, how is Uganda doing?
Thank you very much, Gabriel. And as my colleague Dr. Bagambe said, globally, Uganda is one of the 8 countries that achieved having 90% of people living with HIV know their status, 90% on treatment, and 90% are virus suppressed. So Uganda has done well in that area. But we still have where Uganda has also been able to reduce the child infections by about 77%. But having said that, Uganda still was far less to achieve the target of the special reduction on child infection. And finally, Uganda is not doing well in terms of sustainable financing for HIV and AIDS response. Out of the current estimated about $270 million US, the need for only ARVs in the country, the government is able to put on table about $38 million US on an annual basis. That means the gap of between $270 million US and about $40 million US, that gap is being covered by external donors. The challenge at hand is if there is a challenge with the donors. I've seen how the COVID and other crises and other epidemic come in and they affect the global community, then it means we risk not sustaining the 1.4 million people on treatment. Thank you.
All right. And just to emphasize here, the 1990 target for 2020 was having 90% of people living with HIV knowing their status, and 90% of those being on treatment, and 90% of those knowing their status on treatment having a reduced viral loads. Now, everyone has spoken about COVID-19, and if we could just come to you, Sharifa, first on what COVID-19 and everything that came with COVID-19, the lockdowns, the run on hospitals and what have you, what that has meant for the fight against HIV, especially from the perspective of a person who is living with HIV, but also a person who has made it their mission to go and educate people about HIV and AIDS.
Yeah, I'm afraid to say that COVID-19 took us a step back from the progress that we had made. I mean, when you look at the retention in care for, children living with HIV, the young people and adolescents, it has slowed back because we lost them during COVID-19. We didn't know where they were in lockdown. And when you look at the information they gave us when they come to the health facilities, maybe the phone numbers or where they stay, you find that these are wrong information. Young people are not providing the right information on where they stay. And this affected, how do we take medications to them? How do we make sure that they come back to the health facility even after the lockdown, the way we are seeing now? So when you look at the charts right now, young people are not in care. Most of them have not come back in care. Maybe they are still facing a lot of, difficulties in transport, and maybe they are, we don't know what exactly they are doing, but they are not yet fully back in care. But for those that, we are giving the right information, that we are, that we are able to reach, they were able to get treatment even in COVID-19. We saw peer supporters delivering treatment, door-to-door treatment to clients who needed it. Clients just call in the health facility and they pack the treatment and peer supporters deliver them. So we saw peer supporters doing the work. Young people volunteered to do the work even without any pay. They took the treatment to the clients that needed them, and this helped with them. When you look at viral loads, this helped to make sure that we maintain the viral loads of them not going back. The only difficulty that we faced, that even when the medicine were taken to the young people in the communities where they say there was a lot of stigma. A young person had to disclose their HIV status for someone to bring medications for them. For example, those that are far in the villages, they had to disclose to the district to give them a letter to transport them to the health facility.
Yeah,
so
because of the total lockdown.
Yeah,
and,
because of the total
limitation
lockdown.
on, means of transport.
Yes. So now when you look at that, they were forced to disclose. And maybe they had their own reasons why they had not yet even disclosed in the villages where they come from.
Yeah.
And these were shattered. They didn't have any, confidence. They didn't have confidentiality, and their status was out there. So. Yeah. With this, it made stigma and discrimination rise up, because many of them have faced the stigma, the kusosola, the kusonganwe. So, and this has affected them to continue adhering to treatment, because if you abuse me, if you torture me because I'm taking my treatment, I won't have the courage tomorrow to pick a tablet and swallow it. So I'll be like, why? You're already calling me a dead person. Why do I have to take it? Let me just die. So we have a lot of, people failing treatment because of the stigma that was faced, just because the lockdown was there. Because just imagine if the lockdown wasn't there, this young person would continue adhering to their treatment, and no one would know their business, because it's their status. They have a right to, keep it confident for them.
All right, and it was interesting to hear stories, to read stories of young people who actually used to go get their treatment from a different district or a different, where they are not known, and now the lockdown meant that you had to go to a place nearest to you, and the disadvantages that came with. It's important for us to hear from you, Dr. Vincent, how government has responded to those, to ensure that the progress we had made before COVID-19 came in is not eroded by some of the things that Sharifa has shared.
Yeah, and first of all, I acknowledge the drawbacks that HIV programming experienced because of COVID, but also in the same breath, acknowledge the contribution of the community groups that they made in ensuring that we keep people in care, in ensuring that people continue receiving their medication. And in this, I think they say every cloud has a silver lining. I think COVID-19...
Every dark cloud has a silver lining.
Every dark cloud has a silver lining. COVID has showed us that actually our community structures are resilient. It was the people living with HIV and AIDS during the total lockdown that were able to go to the facilities, be able to pick the drugs, identify their colleagues who are not reporting to the health facilities, and take the drugs there. Even when, as government, we created the community pickup points, we had to work with the those communities of people living with HIV and AIDS, and to work through the networks. So yes, government brought, and we had to quickly, because we did the surveys with our partners, we continued engaging with the networks of persons living with HIV and AIDS to identify the challenges that they were facing. we engaged with the COVID task forces of the districts and secured permissions for the patients to be able to go to the facilities.
Yes, Dr. Bagame, that is laudable. But remember, in March and April, you know, these permissions hadn't yet been secured. In fact, those who braved and walked to the facility, at that time, everything was COVID-19. They were even turned away. As no, we don't have that clinic here today because we're dealing with COVID-19. And that, yes, there was a silver lining, but that also showed big gaps in, you know, our HIV response.
Yeah, and I agree with you, Gabriel, because first and foremost, all over the world, whenever there is a pandemic, the first thing it elicits is fear. And so even with systems that we thought were resilient, because of the fear that was caused by the stories that people were hearing, those systems, by the way, also failed to cope. So I want to agree with you that at the time of the total lockdown, first of all, the health workers themselves didn't know how to handle COVID patients, and they were scared. But also, were the clients, they were fearing to go to the health facilities because they were fearing they could get COVID from there, and that kept them at home. That state of paralysis is what my sister here was describing. But I think the resilience that then came was after. Now, after we started getting a clear understanding of how COVID is transmitted, we started getting messages through from Ministry of Health to the communities on how to avoid COVID, the importance of masking, the importance of sanitizing, the importance of social distance. With time, people started getting back. Now, that is at that point, that's when we're doing an assessment, a series of assessments to establish what are the unique challenges for persons living with HIV and AIDS, and how can we support them to get back to facilities and get their medications. So at that point during the lockdown, it was unfortunate people got off their medications. But to get back, the resilience that we saw in the community groups was that they were the first ones to go to health facilities, pick drugs, and take them to their colleagues. To advise us on where we can put drug pickup points in the community so that we take them there. We engaged with the task forces to secure permissions for persons living with HIV and AIDS to be able to move. Certainly, the information wasn't moving as quickly as we wanted it, and that caused a delay. And as she said, that also meant that some people got lost to follow up. And by the way, yes, the system is recovering these clients slowly, but we know that there are some who have totally disappeared. So the system, but in my opinion, I think the community systems, but to a large extent, also the public health system, recovered quickly, and that's why you see the numbers are getting back on track.
All right. At the time of the total lockdown, we all had a lot of time, and so we read a lot, we watched a lot, and part of what we read and watched were, you know, for example, the community of people living with HIV coming out and saying, government has forgotten us, they're mainly focusing on COVID-19, and we are suffering. We still hear, you know, some people raise that attention, so much attention has been put on COVID-19 and other diseases, and today particularly we talk about HIV and AIDS, have not received their due attention, and yet we had gaps to cover even before COVID-19.
And that one is very, very true. First of all, as a person who has been in the HIV programming for a long time, we have financing gaps that we think, if not filled, we will not be able to treat ourselves out of the pandemic. Interventions that actually are focusing on prevention. We are talking about access to care during the lockdown, but the prevention services were also brought to a standstill. I remember the programs for circumcision stopped. We, of course, have programs for condoms distributions to be able to get condoms to communities and people who might wish to prevent acquiring HIV or other STDs. All those were disrupted. So regarding financing, every time there is a new pandemic, remember, resources are not they are not elastic.
They're not
they
infinite.
Reach a limit, an extent, and they reach a limit. So when every time there is a new challenge, it is nibbling on the already existing resources. And this is what we saw with HIV and AIDS. The resources in terms of human resource, or the human resources that would be focusing on HIV services before COVID, during the COVID pandemic, they focused on services to prevent COVID. But so were logistics, and so were the money itself. And I think as government, we now are emphasizing the concept of integration. We think that if we are able to integrate services for COVID and services for HIV and AIDS, we'll be able to cover more of each of these two challenges.
All right. We will come back to those financing gaps and find out, a sustainable way of dealing with the financing issues. Mr. Ubangizi, your assessment of the way COVID-19 affected, HIV programming in Uganda, and learning from other jurisdictions. What are some of the things that, should have been in place, and the things that can be put in place now? Because in case of another crisis, even if it's not whatever crisis it is, that these systems are found in place and they're resilient.
Gabriel and viewers, thank you very much. In our report that we've been able to release ahead of the World AIDS Day, titled Unequal, Unprepared, and Under Threat Systems, COVID has demonstrated globally and within Eastern Southern Africa country and region that unless government and communities continue to have resilient systems, then we struggle to end AIDS and other epidemics that will keep coming. We've seen countries like South Africa that even despite their strong systems, they are able to move on, but at least they are able to put it very fast. But also in Uganda, in the first lockdown of the phase, I think we are not prepared enough despite the 40 years of HIV/AIDS response and system moving forward. So the first lockdown, I think we are not prepared a lot. We saw people living with HIV cry. We saw them miss their refills. We saw them on the road when they would be required, where are you going? And in our view, we saw them not even having food. We saw, I think we also saw them having stigma at home, because if you've been getting refills from health center X and it is far, and you have a peer educator who is bringing it near the town, then you don't get it. So we saw those challenges. But at least to me, my hope has been that during the second phase, the head of state and Honorable Minister of Health were able to discuss and say, I think we can have a lockdown, but we allow people who need their treatment to go. Let somebody who wants the treatment pass by. And Gabriel and viewers, you noted that during the second lockdown, at least there was some flexibility. the security was briefed. And so whenever you would pass there, whether you are sick or unaware and you're going for health center, it was not as hostile, in my view, as it was in the first lockdown. In the first lockdown, whether you're a pregnant mother, it didn't care, so long as you meet the security on the road. But I think as what we've been able to learn, to me it is a learning process, that by the second phase we're able to learn from the grave mistakes that were done in the first phase of the lockdown. And the second phase, as I say, open up a few things. And we are happy to take note that at least people started, especially people living with HIV, started to go on and get their refills on the roadblock they will bear out. And there was some free spirit and human face attached to this. And therefore, we continue to call globally, especially the United Member States, countries of which Uganda is, to ensure that we learn and we continue to have resilient systems, because these epidemics are, today is COVID, tomorrow is another epidemic, tomorrow is another epidemic. And for example, we've noted that if you are living with the HIV and AIDS and you have a COVID, you are at a double risk of dying and sickness. And tomorrow it will be another pandemic. So
we're told people with comorbidities were more likely to, yes.
So we need those systems. And also we see that even Gabriel, even if you had your 100 million or 200 million, it couldn't save you because the health infrastructure was down. And it would pay you 300 million, but you do not get even a bed. So we saw people getting those treatment just in their vehicle. So I think what we need to push for, and globally what we are pushing for as the United Nations, is for member states, as they invest in roads, as they invest in security, as they invest in a community system and health system, such that it is strong and robust enough to withstand any epidemics that will come in the future.
All right. I'd like to come back to Sharifa. You did mention earlier the issue of stigma and people being forced to disclose their status even when they were not willing, but because they needed to have a permit and what have you. What has that meant for people living with HIV and them accessing treatment?
When you look at what it has made for people living with HIV, it brought us to a situation where we feel that if you disclose, it's the only way to go. You have to disclose your HIV status. No matter what situation you're in, you have to disclose so that people know exactly what you're going in and they could be able to help you in some or the other. And but when you look at, for some people that didn't want to disclose, the stigma rose in terms of like, for example, when you look at discordant couples that a wife didn't know my man is taking the treatment, so it brought in the gender-based violence perspective, whereby if a family, one of them was taking treatment and the other one didn't know, when a young person or a person living with HIV comes to your door and is, handling you a package, you'll be questioned on, what is that packaging. So when you look at a brighter side of it, it made people, to disclose their HIV status, which is good. You need to tell people about your state, and they know exactly how to help you deal with the situation. So it was a good thing. However much it brought, the other issues. But this also encouraged, many people to always speak out for help. When you look at lockdown, it lightened our minds that you do not have to suffer alone. You have a group of people that is willing to support you if you open up to them. So people opened up, and they were helped for those, because when you look at also COVID-19, it brought us a perspective of depression, especially for people living with HIV. The myths and misconception whereby people used to think that if I take a Favrance, for instance, if I take a Favrance, a type of medication, in the HIV regimen, if I take efavirenz, I won't be able to get COVID-19. So those kind of, situation that people started to even ask for efavirenz, that type of regimen, I want that, I want to be put on that. So the myths and conceptions were much, and this caused, confusion in their minds. They didn't know what to think. Am I, vulnerable to the COVID-19? Am I safe because I'm taking these ARVs? Are ARVs the cure to COVID-19? So it rose a lot of things, and people got depressed because of that. And because, like I said before, because they reached out, because they opened up about, their confusion, and them being depressed, they were able to be helped. And
I'm going to come back to you on the issue of stigma, but you've brought up the issue of misinformation, disinformation. I'd like to know from Mr. Mubangizi, was this only an issue here, or was it, happening globally? And how has it been dealt with? Because yes, there are still people who believe HIV treatment does cure, COVID-19.
Okay, thank you, Gabriel, and the viewers. Globally, we still have the issues of social culture, negative practices, and even wrong religious beliefs. And because of that, then people can get lost in their religious or culture beliefs in every part of the global community. And so while we see, and therefore because of that, and if it is not addressed, then we see those misinformations. So globally and everywhere, like in Uganda there, like the same way we have the culture and religious institutions here, and people believe in them, the same way we have it globally. And depending on the information that people pass on, if it is wrong, especially from the culture or religious, if it is a wrong information, then the other may take it as a gospel truth. So while in Uganda, comprehensive knowledge on HIV is still low, in the range of 30 to 40%, we've also seen in some parts of the global community that we still also have those misinformation. But what I said earlier is that the epidemic is more in Africa. More than half of the people living with HIV live in Africa. Okay? More than half of the new infections are in Africa. So even in other parts of Nigeria, for example, in Africa, we have Nigeria, South Africa, they have the highest burden of HIV in this country. And we know that in South Africa and Nigeria, similarly like in Uganda, we still have those social cultural issues and people believe in. And that's why we call upon that we need to end those inequalities, because those inequalities come from wrong information that we get, from negative social and cultural practices. For example, wife inheritance, somebody dying and they don't believe has passed on because of AIDS. And then they say wife inheritance goes on. They don't test to know their HIV or status. And those are this. And some people also, there are some of those religious institutions that give wrong information, Gabriel. And they say that when we pray for you, and we can chase the spirits out of you, and you will recover. And if you have been having HIV and AIDS, that you will recover. But and especially if somebody has, and they tell them, no, don't even get out of ARVs. But also we've seen it there, others telling them get out of diabetes drugs. So those negative information are still a crisis globally, and within some African countries, especially where there are negative social cultural practices, and to remain a challenge. I want to end with an example. In Karamoja, we've been in Karamoja supporting some interventions. And when we went there in 2016, during our scooping mission, we ran there saying, you should not go talk about circumcision, but we know circumcision gives a 60% protective effect. So, but until we engage with the cultural clan leaders, and they are leader when they say one word, every other you stand for it. Until we engage them, then at a time they say, no, I think it is okay. Our children can go far and get this. So I think going forward and working with Uganda AIDS Commission and other partners, and especially the media, especially UCTV and others, is to continuously give the information until it hurts. If we keep on giving it, maybe you remember, in the early 80s when the head of state, His Excellency the President, would you know, the drum, the people of that age, people I think 40 and 50, they remember the drum, and those drum will come and they will cause that there is still a worry. But currently, because we no longer have those kind of drumming messages, we still have a challenge. And I want to call here, since you're giving me an opportunity, to call and upon the TVs. At times there are those that produce messages where people are naked. So as our children, as young as 5, as 10, what they are used to watch on the TV is naked pictures. But if they can have a platform where you also pass on those messages that, look, HIV is still here. Look, you get it by heterosex. Look, but you can protect this one. In school, this is how it is. You tell the people that, you know, sex that is not protected will have, you can have teenage pregnancy, you can also have HIV. I think we can be able to make ends meet.
All right, on awareness creation and, you know, countering misinformation, how was it dealt with? Because I'm sure you remember people believing that, you know, certain regimens, are they called, of HIV treatment could deal with COVID-19. And at that time, the focus was telling people to, you know, prevent COVID-19, wash hands, wear a mask, and what have you. And, you know, what was happening to deal with this misinformation that got very many people on medicines that they shouldn't have been on, and then making the medicines unavailable for those who actually needed them.
Misinformation, as my colleague Jotham and Sharifa have already stated, is a big, big challenge, not only here, everywhere, and I think in all spheres. And misinformation, yes, it could be because of lack of knowledge, but we have also seen a lot of conspiracy theorists, especially people on social media. So you read something, it's totally wrong, but you take it as the correct version. And it's very difficult to change such a person's mind. It's not only difficult to change him, but sometimes such people have followers, people who think that what they are saying is actually the truth, and they keep transmitting falsehoods. And so I think as programmers, we've faced that challenge, and will not be able to address it unless we get support from all spheres, all sectors of life. I want to use one example. There was a time when Ministry of Health was calling people to go for vaccination. And the vaccines were almost expiring in the stores, and people were not going. One call by the Kabaka in Bulange, please come and vaccinate. Same drug, same vaccinators. People went and lined for a whole day, and they all got vaccinated. So those are the collaborations that we need. We know that there are voices in the community that people trust. It could be the cultural leaders, and indeed, in our communities where cultural leaders are, they are highly regarded by the communities. I want to appreciate the Buganda Kingdom and the Toro Kingdom and the other kingdoms. They have come to support the fight against HIV and AIDS, and they have played a crucial role in the fight against COVID. They are religious leaders. Every Ugandan, actually I think 99% of Ugandans are believers. We have very few atheists. And every believer trusts the faith institution that they go to. And once they hear it from their faith institution, they will take it and they will believe it. Now, our role and what we would want to see is that the pastors and the priests and the imams get the correct information. We would not want them to be fed by the conspiracy theorists, and then they take this information to the pulpit. We make an effort to reach out to them, and we've worked with the Interreligious Council of Uganda, but we need to get this information up to the pulpit in Kanungu, in Karamoja, in Serere, and all corners of Uganda. Once people are getting this information from the religious institution, that might change, and indeed it does change their perception of the service that they are going to receive. Of course, also ensuring that as the various sectors are mobilizing the people, the commodities are there. That one also plays a crucial role. I know some people who don't want to go to, who don't go to health facilities because they think they are going to find lines, or they will bounce and they don't get the service. So all those are loopholes that we need to knit together to make sure that once a client, once a person has been explained to and he understands the importance of receiving this service, when they come to the facility, they will receive the service. Of course, also our health workers need continuous orientation and capacity building.
All right. Please go right ahead.
Yeah, the community groups that I talked about earlier. Again, these are sources of trust. People will want to receive a service from a person whom they think that is like them. And the challenge that we have as programmers is to ensure that this community resource person whom the people trust has been well oriented, he has been equipped with the right tools, and therefore is able to give the right service to the persons that trust.
All right, equipping the community people and the health workers, but you will also, you know, as you look for the people, high influence people, isn't there a need to also equip them? Because I will use an example from outside of our borders. Remember some remarks attributed to a high profile person who said, you know, after you've had sex with somebody, if you went ahead and bathed immediately, if the HIV is there, you'll wash it away. And many people believed.
And you are very right that, and again, I think I said it, that if the faith, if the imam or the pastor is going to be on the pulpit, but is misinforming, that is even more disastrous. So this person needs to go with equipped with the correct information. I know the president that you were talking about, and you know, that country was very rich. That country was South Africa. Was very rich. It could have turned the tide against HIV much faster than Uganda because it was resourced. But because the misinformation was coming from the highest office, it took them a very long time. In fact, up to now, South Africa has never reached even halfway of where Uganda is. But because in Uganda, we have had the correct information right from the highest office about HIV and AIDS. And that helps to rally everybody in line.
All right.
The same applies with the COVID, that if we are going to fight and control COVID, we must have the same voice right from the highest office through all structures of government and all structures of society up to the person who needs the service.
All right. As we see infection rates among young people going up, where do young people get their HIV information? And because of what we've just talked about, we need to qualify that, the correct information, because there's a lot of wrong information out there.
Yeah, so when you look at information, young people are so very much on social media. So I would say it's where they get their information about HIV from, because they are always on their phones. There is no young person who you will find take 3 hours or 4 hours without checking their phones. So they get this information from, you know, social media. And this, we need to make sure that as we, you know, make sure that people have the right information, the imams that check, the different stakeholders. We need to make sure that we involve influencers on these platforms, on a social media platform. I look at them like, you know, they are nothing. They're just, you know, being on their phones and playing around. But young people listen to these people. For example, if let's say Martha K puts out a post, people will run to see what Martha K puts there. And they will follow exactly what she says. But if we engage those influencers, social media influencers, and also engage them in the discussions, because they have always been left behind. But we are saying this is the right time to involve them. Make them aware of the information, like the word doctor was saying. Let them understand the introduction of HIV, and they will spread the right information to young people, because we are basing on them for our young people to understand, to get the right information, and to understand how to prevent themselves from getting the HIV virus.
All right.
So we need to engage the social media influencers.
All right. Speaking of phones and social media, please get your phone and use the hashtag CTV Big Debate. Remember to copy CTV's handle at CTV Uganda. You can also copy mine at Gabriel Iguma, and let's make sure that the right information about HIV and AIDS goes round. We need to go for a break at this point. After the break, we continue the discussion, so don't blink.
The largest HIV/AIDS awareness campaign of the years is here. The 2021 Ainokati HIV/AIDS campaign brings you free services like HIV/AIDS testing and counseling, access to family planning information and services, and so much more. Join us on the 1st of December for an integrated community outreach at IUEA and Chitintali. To crown all this, we shall have a musical concert on the 3rd of December with your favorite artists like Spice Diana, Waiki Bender, Levixen, Nati Nathan, Caro Casita, Alan Tonix, Dre Kali, and Easy. We shall also be having special appearances from Madrat and Chico. Jaja Bruce. The Ainokati is proudly brought to you by Reach Ahead Uganda, Global Livingstone Institute, and partners.
As we embark on a journey to realize our full potential, we all need expanded minds and limitless possibilities. We need to be accurately informed. CTV is your growth partner. With reliable, in-depth news, we tell the story from all perspectives. We bring you the story in real time. Catch our comprehensive daily bulletins in Juba Egorovie at 7 p.m. and PM edition at 9 p.m. CTV, don't blink.
Welcome back from the break. Thank you for staying with us here on CTV. The show is The Big Debate, and today, being World AIDS Day, we are discussing HIV and AIDS, the progress that Uganda has made, and what are those areas where we can tighten so that we can win the fight against HIV and AIDS. Globally, the target is to end HIV and AIDS by 2030. I've already seen on our social media somebody has said that target is unrealistic. Well, we're going to hear from the people who are dealing with getting us there. But it is a collective effort. My name is Igoma Gabriel, in studio with 3 guests. Dr. Vincent Bagambe, the Deputy Director General, Uganda AIDS Commission, Mr. Jotham Mubangizi, the Acting Country Director, UN AIDS, and Ms. Sharifa Nalugo, the former Miss Y+. And in the first segment of the show, we got to understand where we are as a country, some of the challenges that persist, and how we're dealing with those challenges. We talked about stigma. Sharifa, some people may not understand when you say stigma. Describe, whether it is from your perspective or the perspective of the people you go out to educate, what does stigma mean when it comes to HIV and AIDS?
So stigma when it comes to HIV and AIDS, I would just say stigma is like the unjust treatment or the unfair treatment that is caused on a person living with HIV. We have the self-stigma, the stigma inside me saying, oh, maybe I am not worthy, the stigma that I cause to myself. But then we have the stigma from the society. That is the stigma that is a lot, because we are saying if you create an enabling environment and a space where I can fully exercise myself, without you looking at my HIV status, then it will enable me to solve the self-stigma that I have. But if you don't create that space, I'll be questioning myself inside me. Am I worthy?
Yeah.
Do I deserve to be on this world? So it all begins with, the community. You need to accept people living with HIV. We have a saying that says that, okay, I'm a person living with HIV. I cannot change my HIV status. I can't, even if I do what. But you can change your attitude. You can change the way you look at me. If you just do that, I might be able to fully, accept myself and take my HIV treatment very well so that I do not infect you. Because when you look at this stigma, it is the one that is causing people to infect others. Because if you stigmatize me, if you tell me you're not good enough, I want to show you that I'm good enough. Meaning, I'll sleep around with people to infect them and see, you said I'm not good enough. I've, infected 10 men here. Now, who is a joke here? So if you change your attitude, if you don't stigmatize me, if you don't discriminate me, I would not have that bad, thinking in my head of going infecting others. But if you do, I will have to infect others so that you feel the same, you feel what I feel when you stigmatize me. So it starts with your community. You have to accept people living with HIV. You have to see them as a human, not as a person who has a status. We say this HIV status does not define who we are. We are more than that. We are human beings, like you yourself who is living negative. So you accepting and you solving the issue of stigma, you stopping to, put me down or seeing me as unworthy, will help me to rise, and maybe we rise together as we stop the new HIV infection.
There used to be a misconception
Yes.
that anybody who had HIV and AIDS had gotten it because they were living recklessly. Is that perception still prevalent among these people?
Yes, that perception is still there. And when you look at the reason why, even when you say it out that I'm living with HIV, someone just put it in their head, oh, she slept around with men, that's why she's living with HIV. But we want to show you that there are other, different methods that someone can get HIV. For example, you have children that have born with HIV and they have grown into, adults. Look at myself as an example. I was born with the virus, but I'm here. I'm already, this age. And if I tell you now, you might think I got it from a man. But we want to say that HIV does not only you do not only get HIV when you sleep around, but you have other methods that you can get HIV. We have the blood transmission. We have the sharp object. I mean, people are forgetting to look at these other factors and only, staging it to a sexuality.
Okay.
Yeah.
All right. Because we have many things to deal with, I'd like each of us to make a comment on stigma and how exactly we can deal with stigma I'll start with you, Dr. Bissett.
Stigma, actually, I agree with Sharifa. Stigma is a feeling. It's a feeling that you could have, you as an individual living with HIV and AIDS, but it could be in another member of society, the feeling that they have towards people living with HIV and AIDS. And in my opinion, it is stigma. It's because of the stigma that society has towards people living with HIV and AIDS, and the stigma that people living with the feeling of people living with HIV and AIDS that they have. Maybe the health worker has not served me in time because I'm HIV positive, or the health worker will not serve me, the health worker will blame me. Those feelings are the reason we are failing to attain our targets, and will not be able to eliminate AIDS until we have been able to fight stigma, both the internal stigma and the external stigma. And to fight stigma, we need to educate the communities. Most of the people who stigmatize HIV positive persons, it's out of ignorance. I know initially it was fear. People used to fear HIV, and again, because of ignorance, people would fear that maybe if I sit next to a person living with HIV and AIDS, I'll become HIV positive. But we have now progressed to where people who stigmatize, it's because of ignorance. So we have to educate and educate and educate. We have to educate the persons living with HIV and AIDS to believe in themselves and have that confidence.
Is this education working? Because a lot of the education is done in urban areas. And when we look at the prevalence of HIV in urban areas, it's higher than in rural areas. Urban areas, I think, stand at about 7.4%, where the rural areas are down maybe 5.3, 5.5%. So are we getting the messaging wrong or something? Because there is more information in the urban areas.
And I think the question you are posing is actually bigger. I think what you are saying is we see more information flow opportunities in urban areas, and yet the HIV transmission rates are also higher in urban areas. And I think so the question is, are we sending the information in the right channels to reach the right people? Perhaps what we need to change, and I think that's what, when you read our new strategic plan, we are segmenting the populations. We need to tailor the information to the specific populations that we want to reach, so that this information is meaningful to the person receiving it. Otherwise, if you are going to send information on radio, and there are radio channels that young people don't listen to, by the way, and this information is meant for a young person, perhaps they have not even heard it. It is blaring, and they are passing every day, but they have not heard that information. And like Sharifa said, supposing you used social media platforms, perhaps you'd reach them much better and they would pay much attention. Right. Suppose you use the social media influencers, maybe they will give it a second look and the information will have reached them. But we should also know that it is not only information or lack of it that causes HIV transmissions in urban areas. We have also the social challenges. Some young people are forced into prostitution, and in that way they acquire, they are at risk of acquiring HIV and AIDS. So programs that build the skills of young people, and also programs that increase the economic livelihood of young people, to give them opportunities to utilize their skills or to develop their skills. All those need to work together to reduce the risk of HIV infections. But for those who have already acquired infections, And actually, even stigma, by the way, also affects people who are not necessarily HIV positive. We are stigmatizing young people. You have heard of stories where when a school-going child goes to a health facility to look for a condom, they are looking at him in a very suspicious manner. And so tomorrow this boy will not go back to look for a condom in the same source. They will start either not using the condom again at all, which puts them at risk, or they want to go through other sources or source it from wrong places. Right. So stigma is really a wave. Unless we thread it out and weave and sew our cloth properly, we will not be able to end AIDS by 2030.
All right. Mr. Mbangizi, on stigma?
Viewers, for me, it is my call for action and going forward that we spend more than 8 hours of our time in places of work. Like Gabriel, you've been here since morning, maybe you are here at midnight. We also spend time at home, and we spend time in our places of worship. So I want to comment on those, and I quickly end. My call is that offer love at home. If Jotham comes and has an environment, you should create an environment such that if Jotham has tested HIV positive, you should be able to welcome him, embrace him, and support him to open up and be able to continuously take the treatment. That way we'll be able to break the issues of stigma at home. The places of work, I want to encourage all executives, the MDs and the directors of these institutions also in the CTV, that you should have a platform where there could be one person that people can confide in if one tests HIV positive, such that people, because if we create that, then people will say, no, at CTV, for us, if there is a problem, you'll not be chased away. Because people feel of stigma, because also if I disclose, won't I be chased away at my workplace? If I disclose I'm at home, won't my husband chase me away? Won't my dad chase me away? So I want to call, or if I'm in places of worship, if I disclose, won't then the religious leader refuse to wed me, and yet I want to wed my love Sharita. So to me, my call would be that the place at the home, at the places of worship, at the workplace, if we could create an environment that we will be able to have 1 or 2 people that can confide in, then people will be able to quickly open up and ultimately will be able to end stigma. The challenge why people don't open up is the fear of repercussions. If I'm a wife and I talk about it, won't my husband chase me away? If I'm at a place of work, I'm the producer for this program and the moderator, I'm Gabriel. If I say it, won't my MD the next day give me a letter to go away? If I'm at a place of worship, I'm going to wed my person who is HIV positive, and the religious leader say, bring a letter, and if you're HIV positive, I want to wed you. Why wouldn't I go do what it takes and I bring a letter that shows a different thing? So at those 3 places, which are where we stand, where we reside, I think we need to have an environment where you can easily disclose.
All right. Well, I have the advantage of sitting next to Sharifa. She was nodding her head as you went through the points, just for the benefit of you who was making the points and for the viewer who probably was not seeing Sharifa. Well, Mr. Mbangizi, you did mention earlier that there's, some statistics from the UN report. I'd like to pick on the parts that talk about, the fact that the trend seems to be worrying among the younger people in Africa. There's that for the children, and then the, adolescent girls and young women, commonly referred to as the AGYW. What are the trends there, and what's driving these figures, higher?
Thank you. Globally and in East Africa, are doing well with adult women. We are doing badly with adolescent and young girls, especially the 15-24. 6 in 7 of the new infection among the adolescent girls So 16.7 are new HIV infection. Okay, it is more 3 times closer to their the boys in the same age group. The second group that we have a challenge with is the children. The children they are born HIV positive. That also is a high number. Lastly, especially in some parts of the town and urban areas, we have high HIV new infections among the key population. Okay, so why do we have the challenge around the adolescent girls and pediatric HIV infections? Is that some of them were born HIV positive and have grown into that. So you have that number that by default is there. Okay. Secondly, these adolescent and young girls, another challenge that we see, which is the issue, there could be issues of rape, but also there could be issues of poverty, there could be issues of unemployment, there could be issues also of testing out. Let me test out, I see how this sex looks like, and without protection. Ultimately, the age 15-24 is an exploratory age. It is an age that also that we've seen that people, sugar daddies and sugar mummies, want to experiment. They have their money. These young people have just finished school. This person has the money, so they want to say, we have the money, let us go for it. I buy chicken, chips, and other things. And at times they are under the influence of some alcohol and other things. This young adult, innocent girl will find him or herself into sex without knowing. And unfortunately, unprotected sex. We've also seen high numbers of them being the sex workers that we see, or sex work that we see in that one. So that's where we have a huge challenge. Lastly, as I talk about Gabriel, because of the COVID, we've seen high teenage pregnancies in Uganda, in South Africa, in every part of the country, Africa. The 2 years of lockdown for the COVID has worsened the situation. In eastern Uganda here, the other day I was in Tororo Kingdom to meet the King Oyo. He was talking with passion and cry with these adolescent young girls as early as 14, 13. So if you see a girl, a woman pregnant, it is the testimony that that was an protective sex. So if it was not protective, and if it was not protective, then it means that by the time the pregnancy came in, if the other one partner was HIV positive, it comes out. And therefore, that's why we see this huge scale up of this new infection around the adolescent and young people. That still is around, and my passion and cries also around the children, innocent children.
Pediatric, yep.
Pediatric HIV infection. The reason we've seen why we see also many number of them is that there are 3. One, their mothers at times, they start on treatment extremely very late. And therefore, the child gets infected within the womb because the mother has started on the treatment extremely very late. Some of the mothers, expectant mothers, start on the treatment, but then they drop off the treatment because the family is not supporting. Also, maybe during the COVID, they could not get the refills, so they drop out. So when they drop out on the treatment, then the child gets infected. And lastly, another aspect is that when a pregnant woman living with HIV is going to give birth, at times they deliver not in a health facility. And when they don't deliver in a health facility, then the challenge is that there are other attendant problems that center around that, and we try to see those bit infection. So Gabriel and viewers, as I end, we have a crisis in this country, but also in the entire region of Africa, especially around adolescent and young girls with high new infection, but also with this pediatric HIV infection. And our worry is that these are the future leaders of tomorrow, and we must sustain them on treatment if they are to live for as many years as 90, as 60, because it means every other year we must spend on that child until they reach that age when it is the normal time for them to pass on, as it were. So right. That's where we have a challenge.
Sharif, I'd like to come to you on adolescent girls and young women. What's driving the rates up, and what can be done to stop those figures and to actually start to bring them down. Then, Doctor, I'll come to you on pediatric you know, the figures among the children?
So first I would say what is driving the number of new infections. I would say it is poverty. Poverty in our society, it is a lot. And if I'm a young person and I get someone who can give me food to eat, for him or her to, you know, use my body, I'll do that. And leave alone food, when you look at, you know, the trends that are happening. Right now we have the iPhone 13 and everyone is yearning to get that. If I get a sugar daddy that can give me an iPhone 13, I'll be like, okay, it's only one night. What can happen? So they'll just forget about everything and go into the sex and have the phone themselves. But we are saying, I'm sorry to say this for some that might be not able to, you know, take me in a right way. But I'm saying give this child information on sexual and reproductive health, sorry. Give this child information about SRHR. Give them information as young as 12, because we are seeing young, you know, children getting pregnant at 13, 14. But if you educated your child about, you know, the use of condoms, they might be able to use them where necessary. If they'll remember in the times of I want an iPhone, I can, you know, have a condom with me. However much I'm going to sleep with this person, let me use a condom so that I could not get pregnant. Let me use a condom so that I could not get HIV. So let's educate young people about, you know, these things that they can use to prevent themselves from getting HIV. Because we might say they are young, but these are the numbers that are coming up. These are the teenage pregnancy we are seeing. We are saying they are young, but they are having sex at a young age. One time a person, there is a lady that I like so much, she said, if they are engaging in sex, they are already adults. So give them information like the way you give the adults the information. Let them know about their rights, about their body, and let them know about, you know, sex in general. Because if we keeping quiet, we are not solving anything. We are into the 21st century where information is out there. If me, I get to, you know, I get to learn about sex on internet or maybe on TV. Doctor said of naked pictures. If I get to know about that, I want to experience. But if my father or my mother sat me down and told me about the HIV prevention tools that I can use, I would remember when I want to practice, I'll be like, okay, but they told me about their condoms. Let me practice with a condom. They told me about, and it will help them sometimes make right decision. Or maybe my father warned me about this. He told me this will come out, I would not do it. But if we just let them be, we just, you know, let them be on TV, on social media, without, you know, the parents engaging into this conversation, nothing will be done. A parent need to spare sometimes to talk to their children, no matter what.
You spend time with young people.
Yeah.
I did read one time that young women are now more afraid of pregnancy than they are of HIV. Is this true?
Yeah, it's very true. It's very true, and people are more afraid of pregnancy because I think pregnancy, a person can see it. You know, if you get pregnant...
African proverb, pregnancy cannot be hidden by hand.
It cannot be hidden by hand. But if I get the HIV, I will maybe go for treatment and you won't know. People are looking beautiful. You can't even tell they are living with a virus. So I think that's the thing behind the whole, you know, getting pregnant, I'd rather get HIV because they know HIV is manageable. But if I get pregnant, there are a lot of consequences. I might drop out of school. My mother will chase me out of, you know, their home. It's what and what. But if I get HIV, no one will know. I just get treatment and I'll be fine. So that's something that we need to correct and tell them that, you know, getting pregnant, it's more harder than, you know, managing HIV. Because here, you're not only taking care of yourself as a young person, but you're also taking care of another child that has to, you know, go to school, feed themselves and all that. So as you say, or as you keep thinking that pregnancy is much... HIV is, you know, easier than pregnancy. Just look at them in both perspective. If you get pregnant, you have a child. But if you get HIV, it is not easy to remember these tablets every day. They have side effects. You know, we are here talking about HIV like, okay, now we've managed it. It's okay. You can take your tablet and be okay. But if Sharifa, a person who was born with HIV, can wake up one day and forget her treatment, Who are you, a person who is going to learn about your status, you know, the other day, and do not forget about this? So you need to know that also being with HIV, it is not easy. It is not being easy, you know, to every time to put a tablet in your mouth. The smell, you know, the burden around it. I actually tell people that it's much harder. We just keep smiling because it's the way to go. We just have to keep smiling and live life on. But it's not easy. When we go back to our beds, me, myself, if I hold a tablet, I, you know, think to myself, I wish I wasn't HIV positive. I wish I didn't have to take this tablet every day of my life. But this is what the world brought to me. But you, who is HIV negative, you have a chance to change this. Do not look for what didn't look for you. If you're going to have sex with someone that that their status you do not know, use a condom or abstain. It's easier because when you abstain, you have, you know, you enjoy sex as much as you can with the person that they have married you with. So.
And we definitely thank you for the courage to talk about this here on CTV, but to also go out and talk to other young people so that they don't go through what you are going through. And yes, the courage to live positively, you know, doesn't take the problem away. And we're glad that you don't let that hinder you from going on to, you know, educate other people. Well, she's raised a number of issues there, but I had said would ask you the question around pediatric, you know, the figures there among the children, what's being done to deal with that, because the figures, like Mr. Mubangizi did state, are not good.
Yeah, so in Uganda, currently, we get 5,300 new HIV infections among children 15 years and below, so 0 to 15 years. It has come down from over 33,000, but 5,000 is still a big figure. And we see that most of those in the category, the majority actually get this HIV from their mothers. And for us really to deal with it, therefore, we must deal with the mother. If we are going to reduce pediatric or HIV infections in children, then first and foremost, we have to prevent new HIV infections in the mothers who produce the children. When I look at actually the adolescent girls and young women, why do they get, why is it the group that is getting most new HIV infections? I think it's because they are vulnerable. We have marginalized them in our society. When a parent is choosing which child to take out of school, it's this young girl. When they are thinking of marrying off early, it's this young girl. When the family is not able to feed or fend for itself, the first person that they think about who should be feeding the family is the girl or this young woman. And all those are vulnerabilities that put them at risk, force them to have sex with people that they don't want. So if we can address those, but it's most importantly, equip them with the skills to avoid unwanted sex, skills to earn a living without having to depend on people that take advantage of them, we will have gone a long way in reducing infections in children through pregnancies. Number two, Jotham talked about mothers who become pregnant, who become HIV positive when they are already pregnant, as the one window we are seeing that is bringing many HIV infections in children. And the reason is because when a mother goes for antenatal and tests negative, she might think that now she's free to have sex with whoever she wants. So that's where the education needs to happen. So that if the mother has tested negative during pregnancy, then she remains negative throughout her pregnancy. At the point of delivery, whereas we have done a lot in the health facilities, we still have a challenge that many Ugandans do not deliver in the health facilities. And we know that if there are unhealthy conditions around the delivery, there is a risk of transmitting HIV to the baby. So as government, we've tried, of course, to educate. We would want everybody to join us in the effort of ensuring or encouraging mothers, pregnant mothers, to deliver from health facilities. Because that way, then they can get the support to protect their unborn babies or the babies they are delivering to remain negative of HIV and AIDS. The other window we are seeing is a mother who delivered an HIV negative baby but became HIV positive during breastfeeding and transmits HIV to this baby during breastfeeding. I should say that the risk of transmitting HIV either to your sexual partner or to your baby is higher when you have newly acquired the HIV. So that's why you find that a mother who was HIV positive and is on ARVs and produces a baby will not transmit HIV to the baby. But a mother who becomes HIV positive during pregnancy, the viral load is high and the risk of transmitting to the baby is also higher. The other gap, of course, that we are noting is after delivery, if an HIV positive mother has delivered a baby, at 2 months, we have to test the baby to see if he or she is HIV negative or positive. Of course, if the baby is positive, we detect that they are positive at that stage, then we put them into care. But in the event that they are negative, then we educate the mother on what to do to ensure that the baby remains negative.
All right.
The gap is that it is difficult to get these babies to test them at 2 months. And by the time they come later into the programs, maybe 6 months, sometimes even after 2 years, then you find that the baby actually got infected with the HIV. So I think it is sensitizing the mother through all the stages from conception to pregnancy, to delivery, to taking care of the baby until this baby is weaned off.
All right.
They need to stay in the service. They need to keep coming for our services. They need to keep checking for HIV, and they need to protect themselves from acquiring HIV and AIDS.
All right. Sharifa did, state here very passionately about how hard it is to adhere to the treatment. It reminds me that, Uganda AIDS Commission did announce that Uganda was doing some trials for injectable drug, and it was supposed to be ready by 2021. And this drug, other than moving away from taking the tablets every day to you get one shot, I think, for
3 months.
For a couple of months, I think 8 weeks or so. How far with that? Because this is 1st December of 2021.
Really, that is still a research. Trials are still ongoing. And of course, as you know, some drugs actually become a success, but then you have to go through the process of producing them, then the supply chain until you get them to the health facilities where the drugs are given. But as we talk now, we don't have those products on our shelves.
Has the timeline been changed for delivery of those products?
You could say yes. You could say the timeline certainly now is no longer 2021. Perhaps let's see if it will be next year. I don't know if Jotham can give.
Well, let's bring Mr.
timeline.
Mubangizi in on that injectable, drug.
Yes, thank you. The United States agency, the U.S. family, American family have been able to put some money on the table and as a partners. And this testing should be able to, piloting should be able to start in the next year. You know, we've had around 2 years of challenges around the COVID with its attendant challenges. But even Uganda to be able to test out that is a good testimony that yes, we can be able to find out how things look like. Uganda was able to test out the SMC, safe male circumcision, and the research was able to be used worldwide to scale up safe male circumcision. So Uganda will be able to test out that. After the testing it, of course, it will take a lot of time. But these are great advances within the science to be able to reduce the burden and reduce what my sister was sharing on what can be taken. She will tell you in the many earlier years, if we meet Major Ranga, they used to take those huge and many tablets. But the science has kept on advancing, and we do hope as we debate and as you assume, is it possible to end HIV and AIDS by 2030? Yes, we'll be able to end HIV and AIDS by 2030. We'll have those injectables will come on board. As a science will come on board to bring new innovations. And we'll be able to also break other barriers that we talked about, those inequalities. And yes, we should be able to end HIV AIDS by 2030.
Do we have a timeline on the injectable?
We should be able, not now, but we should be able to have at least in the next 2 to 3 years, we should be able to have some kind of good science around the injectable.
Okay.
Yeah.
All right. If we could move to the issue of funding, you did talk about it earlier on, and especially in the Ugandan context, the gap. Uganda's HIV, response is highly dependent on donor funding. If you could just, because there's definitely some people that joined a bit late and did not hear, what's our current status and what gap do we need to fill as a country?
Thank you, Gabriel, and viewers. I will just confine myself to especially the focus on where the donors are putting in money on ARVs. Currently, on an annual basis, we require about $270 million US, and the government of Uganda has about 38, call it $40 million US that they contribute, they allocate for ARVs component. I'm not going to the health workers, no. I want to just say, because the health workers, with or without donors, they continue to be available. But I want to say without donors, if we're talking about ARVs of a bill of $27 million US annually.
270.
Yes. Okay, annually. And the government is able to put in about $40 million annually.
Then 230.
Yes, that's
million
a
US
gap.
dollars.
And that's what our friends from Global Fund, our friends from the American people and others are putting on the table. My worry and the worry of any, especially from the country and from the United Nations systems, which is United Systems is supposed to engage the government to be able to take on the ownership of their response, that when 1.4 million people living with HIV and you are able to meet only $40 million out of 270, to us that's a worry. The COVID has demonstrated that American and other countries were able to be affected more even than the African countries. If we get another pandemic, God forbid, and it affects them that way, then it means we'll struggle to sustain our 1.4 million people HIV on the treatment. And that's why we're calling upon the government and other partners that be on how we can be able to increase the budget allocation, in particular for ARVs. The health workers are doing well, the health infrastructure is there by government, but I think the component of the refills, every day we must have that refill for somebody to take, and it must be paid for. Currently, and unfortunately, a big percentage is being paid for by external bilaterals.
Dr. Bagambe, how is this gap being filled? Uganda AIDS Commission is in the center of this. Of course, the Ministry of Health is. But we, with those figures, for example, of 270 million US dollars, we bring slightly less than 40 million US dollars as a country. for our citizens?
Yes, for our citizens, as you put it. True, if you look at the HIV bill, and you even zero down as the Jotham did and look at the bill for putting antiretrovirals in the health facilities for our patients, the biggest chunk is from donors. Managing HIV programs is not cheap. It's a very expensive venture. And I want to assure you that if we didn't have the support of donors, it would have been very challenging or very difficult for government to put all these resources. Perhaps we wouldn't have put the percentage of patients on treatment like we've been able to achieve now. But I want to inform our viewers that the actually government, yes, its proportion now is $40 million US. If you convert it into Ugandan shillings, that's over 120 billion shillings. And it has reached here progressively, because previously the bill was smaller. Government contribution to antiretrovirals was about 90 billion, perhaps 4 or 5 years ago. It was initially 75, then it increased to 90, then government increased it to 100, and now it has increased it to around 120 billion Uganda shillings. So in terms of the proportion to the Ugandan budget, that's not a small contribution. But when you convert it into dollars, because antiretrovirals are largely procured using the dollar, we produce them, but also the factory needs raw materials, and it has to get them to source them from
Also,
outside.
if you convert the 270, it's a big figure, almost $1 trillion.
Exactly. When you convert the 270, it's a huge figure. But the point I was trying to make is that I think, yes, government needs to do a lot, but it has not stagnated. It has been trying to put in an effort, depending on the resource envelope, but also to ensure that HIV is prioritized. I'll also tell you the other strategies that government is putting in place. I think one of the most innovative strategies is what we are calling HIV mainstreaming. We now have guidelines for all sectors in government. When they are budgeting for their annual budgets, they must include a component for HIV and AIDS. So if you are in the fisheries sector, agriculture and fisheries, you should have a component that you will be able to reach out to the fishing communities through the agriculture sector.
Okay.
That will not contribute, of course, to antiretrovirals, but if we are able to prevent new infections, then will not be, the bill for antiretrovirals will not grow. So all sectors, including mining, including transport, you have seen on the roads, the road contractors, they must make sure that they have small programs that are able to prevent HIV infections, either to the construction workers or the surrounding communities.
All right.
So that's another mechanism. And in our opinion, if that is strengthened, it has a potential for sustainability. Because like Jotham has said, the donor support, which is funding the bulk of the HIV program, it means that tomorrow if donors said, no, we cannot give you the money, then we'd be in trouble with our HIV program. But if we have within our budget programs that each sector is able to take to the communities they serve, to the populations they serve, then so long as government of Uganda is making budget, that component will always be there. I am sure you have
Do we have
also...
targets for getting off donor dependence for in relation to HIV?
For now, really, at least, and you know, of course, the government of Uganda plans in the medium terms. So we now have the third national development plan up to 2025. Certainly that one, we plan to progressively increase government contribution to HIV, but we will not be able to do it alone without donors. But if you look in the long term, Vision 2040 and beyond, yes, we see prospects that the Ugandan economy will get us out of there, and get us to middle income, and that creates more resources, and hopefully at that point we'll be able to stand on our own.
Okay. Well, the time really flies, and we now need to start bringing this to a close. Sharifa, let's start with you on recommendations, because actually, let's start with your recommendations in relation to, you know, the financing, because I know that young people need services like, what do you call them, safe spaces, yes, and what have you. And you've talked about, you know, programming focusing on young people, social media and things like that. You know, your recommendations on how that can be handled.
Yeah, so I have a belief that in order to do something, you have to put in yourself. So if we are looking at financing of HIV, this HIV is in our community. It is not with the donors or with the government. It takes you, a person, to put in what you have, pay the taxes. And we have the AIDS Trust Fund. Put in what you can. And we also have the $1 initiative. So we have initiatives that are there for us to, as a community, to put in, to invest in ourselves, to see that, okay, by 2040, if there is no medication, I've put in $1, or I've put in, you know, my 3,000 shillings, I am investing in myself. So if there is no medication, we can use that to, you know, buy medicine for you. And so I'm urging to the community to invest in, put in the money. We have the AIDS Trust Fund and the $1 initiative. One of them will do, but contribute yourself. Let's not wait for the government to do everything for us, but contribute as you, a person. So that's what
we have a global target of ending AIDS by 2030. Many people are not very optimistic about this target being realistic. In fact, even one of our viewers did send a message saying it's unrealistic. What's your view on, you know, whether it's realistic and how we actually can get there?
I believe ending AIDS by 2030, it's actually, we can achieve it. We can do it. If we did, if we reached the 90-90-90 and we are now on 95-95, we can do it. It has shown that we can do it. So it needs all of us to, you know, come together.
Concerted effort.
Yes, concerted effort. Making sure that you, a person, you're responsible for your health. You go and test for your HIV status. Because when you go and test, then you know, and if you're HIV positive, you'll be able to start medication and maybe adhere to the treatment and attain a suppressed viral. So it takes you, a person, to also, you know, say, let me go for testing, because a lot has been done. Ending HIV, ending AIDS by 2030 will need all of us to put together our efforts and our concern to say we are looking at this target and we must complete it. So go for testing. Go for testing, take treatment, and let's have an undetectable viral or a suppressed viral.
All right. Dr. Vincent, are these targets achievable, and how do we move forward? How do we go towards
Yes, Gabriel, the targets are achievable, but allow me to first clarify to our viewers the difference between ending AIDS and ending HIV. Because we will not end HIV in 2030. We have young people like Sharifa, we have put on treatment. These people are going to live up to their age 90s, into their 90s. So 2030, they should still be young. She'll be having HIV, but she'll not be having AIDS. The target that we are talking about of ending AIDS, we want to end AIDS. And yes, we will be able to achieve it. If you can have 100% of people living with HIV and AIDS tested, and they know their status, and we've been able to link them into care, and therefore they are taking their medications, and they are taking their they are adhering to their drugs, so they are virally suppressed. We will not be seeing people dying because of AIDS-related diseases, and that's what it means. HIV-positive patients will be dying like any other person dies. They will also be dying out of accidents. They will die because they have a pressure, like Bagambi has pressure. They will be dying of other natural causes, but not because they have AIDS. And that one is achievable. It is achievable if we are able to fight and eliminate stigma and discrimination in this community. It will be achievable if, when you test and you are positive, you are willing to go into care and you adhere to your drugs. Jotham has just talked about the ever-evolving new technology. So we are very hopeful that we are going to see even better acting drugs that are easier to swallow, that have fewer side effects, but are more effective. So if we have those also on the menu, on the table, and we have people going out for them, I don't see any reason why we will not be able to end AIDS by 2030. Yes.
Do you have a recommendation around funding?
In regard to funding, I appeal especially to the parliamentarians, because we always talk about government. Even somebody who meets me in my village, he looks at me and says, I am government. But the government has arms. Appropriation of budgets is by parliament. So my appeal to parliamentarians is, please advocate for additional funding towards HIV and AIDS.
All right. Sharifa mentioned the HIV, AIDS fund. Is that
the AIDS Trust Fund?
The AIDS, yes, Trust Fund, yes. Is that helping?
The AIDS Trust Fund, as our viewers might recall, in 2018, Parliament passed a bill that a fund be created where especially beverages, whoever takes beverages, a portion of the tax is collected and put into that fund and dedicated towards HIV and AIDS. That bill was assented into law by His Excellency the President, and as we talk now, that bill actually sits, it is supposed to be implemented by the Ministry of Health, but the Ministry of Finance must first create that account. So it's really a process, and the last meeting...
So it's not yet functional?
Yeah, it's not yet functional.
All right.
Yes.
Mr. Obangezi, your recommendations?
Thank you, Gabriel, and viewers, and as we come towards the end, yes, we are in sight to end AIDS by 2030, and I'm happy Dr. Bagambi has clarified. Once we achieve the 95-95, it means we'll be able to, those people living with HIV will not be able to transmit, and if they don't transmit, then we'll have 0 new infections. If they're on treatment, we'll have 0 AIDS-related deaths. And if we do that, also if we address issues of gender-based violence, the society norms, and those negative cultures, we'll have 0 rated stigma. And so the 0 new infections, 0 AIDS-related, 0 discrimination, those will ensure that we'll be able to achieve the 95-95, and we'll be in the sight to reach the end of AIDS by 2030. In terms of financing, there are 3 options I put on the table. One is around the government appropriation of additional fund. I also recommend around the health insurance, such that you can be able to put money on the table. And ultimately, the government of Uganda State Uganda Health Commission has started mainstreaming guidance where each of the sectors will allocate 0.1 of their budget sector such that they can implement. I want to call upon the private sector everyone, even CTV here where we are, and every other private, call it a school, call it a road, that they could have a fund that can be able to support their workers. Because cumulatively, if each institution can support their workers or anything they can do to have a workplace HIV policy, we'll be able to reduce stigma, we'll be able to reduce discrimination, we'll be able to have zero rated deaths, we'll be able to have zero new infection, and we'll be in the right way to finance our response and end the AIDS by 2030, but may continue with the people living with HIV on treatment, but they will be as any other person who is on diabetes, drugs, and other aspects.
All right.
Yeah.
Mr. Jotham Mobangizi from UNAIDS, Dr. Vincent Bagambe from Uganda AIDS Commission, and Sharifa Nalugo, former Miss Y+. Thank you for being on the big debate.
Thank you very much.
Dear viewer, today we wear the red ribbons in remembrance of those that we've lost to HIV and AIDS, but also to continue to create awareness about HIV. You have heard what the targets are, and these cannot be achieved by any single entity. It's got to be a concerted effort. So let's work together to kick HIV and AIDS out of Uganda. From me and our panelists for today, it's a good night. God bless you. Till next week when we have another edition of The Big Debate. Don't blink.